This is another Med Twit this week. I'm Chris the Chiu Man Chiu, and I've got a great tweet. You probably heard from this guy before. So this is from Dr. Tony Breu, and you can see here this tweet that I have. So I'll start off with a question because it's always about the how with Dr. Breu here. Why are AST and ALT relatively low in alcoholic hepatitis? Other forms of acute hepatocellular injury, e.g. acute hepatitis B, often manifest with very high AST-ALT, greater than 1,000. Values greater than 500 are rare in alcoholic hepatitis. Why? And of course, you can see here that I didn't pick very well. Obviously, I don't know anything about it. I picked the one that only 55.9% people chose. So unfortunately, I need to learn a little more. And, I have the perfect person to help me. I have Dr. Tony Breu. Tony, how are you doing?
I'm doing great. Thank you for having me on, Chris.
Well, thanks for coming on. So I got this question wrong, and I was in the large minority of people. So apparently, a lot more people understand this better than me. Do you want to first talk about how you came up with this question and why you wanted to address it?
Well, here's the thing. I'll tell you that if you look at the four options, the option that I had intended to be the correct one, the fourth one, that the fact that the AST and the ALT have a cofactor missing, it could be that that's not the correct answer, because I will tell you there is not a lot of literature on this topic. And when I wrote the thread, that was what I intended to be the most correct of these four. But as we may talk about, when we go over the tutorial, other people responded to this thread with comments that may suggest that my answer, right, that a cofactor, specifically B6, is missing or low, that actually may not be the most important answer. So I'm not going to tell you that clearance by the kidney is the correct answer, but it may be even the case that I didn't even get it right. So there's some, you've got something to work with. So I'll tell you, the reason I wanted to look into this is, I sit in on a lot of morning reports, and I find that when junior learners get presented with a case of alcoholic hepatitis, right, it's typically a patient who's got an elevated bilirubin, usually, over 5, sometimes double digits, sometimes, over 20, 30, or even over 40. And very, very mildly elevated ALT and AST. As I mentioned in this first tweet, very rare to be over 500. And this pattern, that bilirubin, that ALT, AST in a patient who has alcohol use disorder, the senior clinicians immediately recognize that as alcoholic hepatitis. But the junior learners struggle because they don't know that pattern recognition yet, and it doesn't make sense to them, right? They say, this patient doesn't have a pattern of hepatocellular injury. I'm used to, LFTs, AST, LFT in the thousands, right? Why is this patient only having it in the low hundreds? And the bilirubin is sky high. That looks like cholestatic. That doesn't look like a hepatocellular injury. And so I think they struggle with squaring that, and just frankly, just learn that is the pattern for alcoholic hepatitis and accept it. And for me, for over 10 years, I kind of just accepted it. I don't know. Does that ring true to you? Like, that like.
Oh, yeah, totally. Like
this pattern maybe didn't make sense at first, but you kind of just accepted it and moved on.
Well, I mean, there's so much in medicine that is just like, yeah, this is just how it is. Honestly, I don't even know if I ever knew there was good reasons for it, or at least, what theories were or had research into it, which is why I think that's why this tweet really reached to me, like majority of your tweets, because there are always questions that you bring up that I had thought about, but not thought about at the same time, and that's why I always get such great joy out of reading the work that you've done.
Yeah, I mean, my favorite kind of questions are the questions that people didn't realize they wanted to ask, and usually they're questions I didn't realize I wanted to ask until I identified there's a gap in my knowledge. So I'll say a few things about this, in terms of the background and the explanation. So first, if you go back to many decades ago when alcoholic hepatitis was first described through now, it's pretty consistently the case that that this pattern is true. Relatively low AST, ALT, and I'm using the word relatively because, as we mentioned in the first tweet, compared to other acute inflammatory conditions like acute viral syndromes like Hep B and Hep A, toxins like acetaminophen, autoimmune, those often have AST and ALT values significantly higher. And if you believe that alcoholic hepatitis has an acute component to it, you got to ask, like, why not this? And maybe it's just not inflammatory, but that's not the case, right? The second tweet attempts to or the third tweet attempts to make the case that, yes, this is inflammatory. Yes, this is necrotic if you do biopsy. So it's not, you can't just say, well, this isn't an inflammatory state, because biopsies clearly suggest otherwise. And so when this was initially explored a few decades ago, what people seem to coalesce around was the low level of pyridoxine, or B6, a vitamin that is an essential vitamin. So it's something that we have to ingest. In patients with alcohol use disorder, were found to fairly routinely have low levels of B6. And it turns out, and I didn't know this before looking into this topic, but it turns out that B6 is an essential cofactor for the transaminases ALT and AST. They don't function without B6. So it shouldn't be too surprising that if you've got a markedly depressed B6 level in a patient who has alcohol use disorder, that you are also going to have a markedly depressed transaminase level. And the effect is greater on ALT than AST, but I believe in the reading that I did that you can see it with both.
Now this.
So far, does that make sense?
Yes. Now this ties into an old tweet of yours back in September 2018 about AST and ALT ratios, right?
That's right. So in that we talked a little bit about why that classic ratio greater than 2-to-1 in alcoholic liver disease. Why is that ratio greater than 2-to-1? And the kind of take home was that it's both an increase in AST by virtue of the release of mitochondrial AST from the alcohol, and a decrease in ALT as a result of this B6, this pyridoxine deficiency. And so an increase in AST, a decrease in ALT, unsurprisingly, you're going to get an increase in the overall ratio of AST to ALT.
Now, you discussed that it's not just B6, so you can give B6 back and it doesn't resolve the issue, correct?
Yeah, so this was also something I didn't know, or if I knew at some point I had forgotten. So B6, again, pyridoxine, probably most commonly we as internists see this when we give it to patients who are on INH therapy. That is not the active form. The active form is pyridoxine 5-phosphate or pyridoxal 5-phosphate. And so it does need to be converted. And it turns out that the PLP, right, this active form, is the form that you actually really need. And we go over it in the tutorial a bit. Excuse me for a moment. We go over in the tutorial a little bit, like how was that discovered? How do you know it's like one versus the other? And the reality is it doesn't matter that much, excepting for the fact that if you give someone massive doses of B6, you're probably not going to see a marked increase in ALT AST, because you don't need the B6, you really need the active form, this PLP. Yeah. Sorry, someone's trying to call.
Well, you're a popular guy, Tony. So, all right. So, and you also talk a little about the acetaldehyde, right?
Yeah. So the I think the immediate question that follows is, okay, fine, patients with alcohol use disorder have a low B6, but like, why do they have a low B6? And intuitively, I always just assumed they just weren't taking in enough of it, because, like, if it's an essential vitamin that you got to eat, and some patients with alcohol use disorder have malnutrition, well, that is obvious. Again, won't go into the details, but it turns out that poor ingestion, though it may play a role, isn't the predominant problem. The predominant problem is acetaldehyde, right? The first metabolite of alcohol. This thing is just a total terror on the body. And one of the things it does is it displaces the active form of B6 from these binding proteins. And when it's displaced, it allows it to be degraded more quickly. So it may be poor ingestion, but it's also undoubtedly increased degradation of the active form of B6.
Cool. Anything else you want to let the watchers or listeners to this know about your tweet?
So, I mentioned like very early in this discussion with you that this explanation may not be the actual real explanation. And I want to sort of make reference to two people. There may be others who made this point on Twitter and I missed it and I apologize, but Russell Goodman, who is a hepatologist at MGH, and Mitchell McGill, who has a lab in Arkansas, I believe on liver diseases. They both made the point that PLP is actually added to the lab assay for AST and ALT in many labs, not all labs, but many labs. And the intent is to mitigate the effects of B6 deficiency. So you would think if the only explanation is low B6 levels or low PLP levels, that if you add it to the assay, it's gonna like increase it. And it doesn't seem to bring it up to levels in the thousands. And so maybe that's an argument that there are other mechanisms at play. I think that's a pretty compelling argument. The reality is in the last 10, 15 years, I haven't seen much research on this topic. And so, this is the best I had to go on.
Gotcha. All right. Well, thank you so much for your time. I do want to finish off our talk with you providing, or at least suggesting one of your favorite tweets of the week. And I think you brought up Dr. Glockenflecken, who's a friend of the Curbsiders as well. He had TikTok, which unfortunately I am not on. Are you on TikTok?
I see it on Twitter. That's it.
Well, he had a great tweet using I think the voices from The Office. I don't know. Let's see if I can. Maybe I will try to do a screen share on this one. Let me see.
I mean, I think everyone who's watching this has seen it. But the reason I particularly like this is one, it was funny before you realized it was Jim and Creed. And then when a friend of mine, Chris Worsham, pointed out on Twitter that the voices were actually Jim and Creed from an episode where they were playing chess, it just made it like infinitely better, and it was already amazing. I mean, everything that he does is just, incisive and funny and frustratingly so to some extent.
Yeah, he's definitely had some very good. I guess they're all TikTok videos over the last couple of weeks during the COVID-19 stay at home. Because as a ophthalmologist, I'm sure his he's not doing a whole bunch of work and spending a lot of time with his family. And I think he was just doing lots of really, really funny and on the nose content. I really think was quite good. So, so for people who haven't seen it, it came out May 1st. I'll link it. I'll thread it below. And if you're in the tweet, and I'll link it in the YouTube. So, well, Tony, do you have anything else to plug? Otherwise, I'll let you go.
No, nothing else.
All right. Well, thank you everyone for watching and listening to MedTwit this week, and I'll see you guys in the next one. Bye.
Thanks, Chris.